Okay, we'll get started in just a moment. Nice, we have little chimes each time someone joins the meeting. Tulsi, is this your last EP meeting of all time?
It's my last EP meeting as a fellow, yes.
Wow. Well, you're always invited.
Aw, thank you.
And to be up at 7 in the morning on Mondays.
Right, thank you.
Is the time zone the same in Cleveland? I think it is,
It,
right?
it is, yeah.
Okay.
So it won't be too different.
All right. Somewhat abbreviated one. Let's see how it goes. All righty. This is a 15-year-old obese male who comes to the emergency department with palpitations. So we ask Dr. Bezdakova if she has any thoughts on this tracing.
Good morning, Dr. Pass. So looking at this tracing,
Remember, I do sometimes try to trick you.
yeah. So I see upright P waves in 1, and then in 2 and 3, don't really see them. See, almost it looks like a sawtooth type pattern. I think I'll look at the rhythm strip in V1.
Mm-hmm.
Do you say that it's trill flutter?
Well, I guess that's the question, is this atrial flutter. What do you think about leads V4, 5, and 6? Do those look like sinus rhythm?
They do, yeah. It does look like sinus rhythm. The
What about
PR,
lead? Yeah, what about lead 1? Does that look like sinus rhythm?
that looks like sinus rhythm.
Right. So can you be in sinus rhythm in 5 leads, but not in the rest of them?
No, no.
So what do you think this is, though?
Hmm. Is this artifact?
Correct. This
Okay.
is artifact. So you want now, it's conceivable you could have people can have AFib in their left atrium and be in sinus rhythm in their right, but that's extremely unusual. Certainly in pediatrics, it is. So, you want to look to see whether you can tell in any of the leads more clearly. This is one of the advantages of a 12 lead, which is why I'm always saying whenever someone's asking you to assess a rhythm, that the very best test you could get if you have a choice is a 12 lead rather than an A-wire or other things, because it allows you to look at the rhythm in different directions and in different vectors. And so we can see clearly in lead 1, which is typically reading a similar vector to V6, that there is a clear P wave followed by a QRS, a T wave, and clearly looks like sinus rhythm. But despite that, simultaneously in leads 2 and 3, we see this thing that looks something like a sawtooth pattern, but in retrospect has to be artifact because the other lead is so perfectly clearly in sinus. Okay. So if you can identify sinus rhythm in leads, then you have to ask yourself strongly the question, is it possible that the other leads are artifact, particularly since we know that all the leads are simultaneous on this tracing. Now, I will tell you there are some machines where V1, where the rhythm strip is not the same rhythm as the above leads, but in all of our EKGs at Sinai and at most EKG machines, the rhythm strip at the bottom is simultaneous with the rest of the tracing. So this is just an example of sinus rhythm with artifact.
Can I ask a question about that really quick?
So you may.
So just not this one, I guess in particular, just you mentioning sinus in the right atrium and fib in the left.
Mhm.
Like you know that by
That can
EP,
only be
like
that can only be determined in an EP study.
yeah, because it's gonna look like sinus on the thing, right? On the
That's
on a
right.
12 lead, right? Okay.
That's right. And so there are times where it's usually more flutter, where one chamber is in flutter and the other is not. Usually that's because there's some form of conduction block somewhere that allows a
Uh-huh.
portion of the atrium to be doing something different than the rest of the atrium. But yes, you would need intracardiac electrophysiologic proof, I think, to prove that.
And those patients would be complaining of palpitation still? Like, I mean, not that, again, you mentioned like it'd be really not common in pediatrics, but just like in
So
terms of what would raise your suspicion for that, or like somebody with a history.
I guess the first thing I'd say is it's very rare. And the
Yeah.
second thing I would say is this is typically something seen in an EP study in which a patient would be under general anesthesia.
Okay.
But the
Okay.
reason they're there is presumably somebody thought that they had an atrial arrhythmia, right? They're there
Yeah.
for ablation. So I think what happens is that sometimes when they're doing ablations for things like AFib, they
Hmm.
while they're drawing their conduction block, you can get some funky rhythms. In other words, until they're done with everything,
I
you can
see.
sort of block part of the atrium from the other part of the atrium, and
Yeah.
some kind of weird looking tracings, and so it's there are a whole bunch of those weird looking types of tracings where it's obvious that the left atrium's in fib, but the rest of the heart is not. So it's
Got it.
unusual, but it can happen. Okay, thank you for that. All right, this is a patient who comes into the clinic 10 days after for a routine follow-up following ASD closure. What's the evaluation and how would you manage this? So why don't we turn to Dr. Mukhopadhyay of the Upper East Side of Manhattan for her.
Good morning, Dr. Cass.
Good morning.
I'm looking at the rhythm strip, and I find a P wave followed by a long PR interval, and a QRS, and then a T, and then a P
I
wave.
just want to make sure so you're saying this P wave has a long PR interval.
Yes.
And then a T wave. Okay, I just want to be sure we're on the same page. Go ahead. Thank you.
Yes. And then I have someone's record. Okay, sorry, I keep hearing myself, so I was wondering if
Maybe mine's
something's
unmuted. 1 second. Sorry.
And then I see the P
Yeah, it was
wave,
me.
which doesn't have a P wave, and a dropped QRS complex, and then I see a QRS complex which looks similar to the other QRS complexes. And then something which looks like a P wave on top of a T wave, and then no QRS complex following that P wave, but then another P wave later on. So I think P waves are.
So is there a consistent relationship of the P waves to the QRSs here?
No.
Not really. Right?
Yeah, so I think this is probably a complete heart block.
I think you're right. I mean, the only mild caveat is that this PR interval and these three seem to have a similar PR, so it makes me wonder if perhaps there's conduction. On the other hand, one of the things that's in favor of the diagnosis of complete block is the fact that the R to R interval is not varying at all. Usually, when patients have high-grade second-degree block, there may be occasional atrial capture with, AV nodal conduction with capture of the QRS. So, yeah, I think this is complete heart block. So this is clearly something that would be very upsetting if you were in clinic a week after placing an ASD device. Do you think this is likely after a large ASD device or a small ASD device?
I think it's after a large ASD device, but I think I might be wrong.
No, you're right. Why would a
Okay.
large ASD device potentially cause this?
If there's a large ASD device, I would think the rim around the ASD, the septal atrial septum is not a lot, and probably that's the reason it's going into the interventricular septum. I mean, it's like while trying to repair or putting the device in, there's some injury to the interventricular septum
Well, I
or
mean,
the junction of the junction.
why would we
Uh,
injure the interventricular septum?
Sorry, the AV junction. There might be some
Yeah.
injury to the AV junction and leads to the complete heart block.
So where is the conduction system sit normally? What triangle does it lie in?
The triangle of Koch,
Okay, and what are the borders of the triangle of Koch?
Koch, sorry, the tendon of Todaro, on one side, the anterior septal leaflet of the tricuspid valve on the other side, and the ostium of the coronary sinus
Exactly.
sits in the base of that triangle.
Right, and so that's exactly right. And so that's like right there at sort of towards the inferior anterior border of an ASD. And so if you don't have a very large rim, you put a very large device in, you can get a heart block. It's the same reason why when patients have ASD repair by surgery, very rarely with a very large ASD, a surgeon can inadvertently injure the conduction system if they're not careful. Okay, so you're in clinic and patient says they feel fine. You're not feeling so fine. And what are the options now?
So the heart rate of the patient, 1, 2, 3, 4, 6, 7, it's around 30 to 40. So, and the patient has bradycardia. I would like put in a pacemaker for this patient.
Okay, so we're 10 days out. Uh, I agree the patient might need a pacemaker. First of all, would you admit the patient or would you send them home? In other
I would
words,
admit the patient.
yeah, we would certainly admit a patient like this. I mean, how many times have you seen, you've only been a fellow for a year, but have you seen any patients come back with complete heart block following ASD closure here?
Not too many times.
Not too many
Or
times. How about zero?
0.
Okay. So if you see that, so that's a very unusual finding, and it's not one that we would be excited or happy about at all. Okay, so we would admit this patient because we would be fearful that although the patient's been fine, that the heart rate might even get slower. Now, any other things you could do other shy of a pacemaker?
Um, uh, I would do an echo to see how the cardiac function is, but
Okay, device is in
um,
great position. Echo, Dr. Ezon tells you it's a very large device. He's surprised that that thing fits in the patient's heart, but it's in the proper position. There's no residual ASD. The function's fine. Rob, did you
okay.
notice the heart rate slow? So anything else you might be able to do? So the device was just put in 10 days ago. And by the way, the patient did not have heart block before surgery, before the catheterization. So this type of case came up in the, I'm in a chat group for the Society of Cardiac Angiography, or maybe it's the Pediatric Interventional Cardiology Society. I'm a member of both of those. Anyways, people asked the question, what would you do? And the question was, would you take the device out and see if conduction recovered? Would you leave it and possibly give the patient steroids on the theory that there is inflammation around the device related to the device, essentially pushing on the healthy tissue around it? And personally, if I saw someone 10 days out, I would definitely take the device out. And the question then is, and the reason I would say that is because 10 days is a long time. If it was like a transient injury, you would expect that the conduction might recover. But in actuality, what the person who submitted this case said they did was they actually started steroids on this patient and saw resolution of this within, I think, 48 to 72 hours. So definitely when you have an acute injury in the cath lab to the AV node, we do tend to give steroids. And I one time very early in my career had a patient who came back about a week after an AV NRT ablation and was in second-degree heart block. And I admitted that patient and put them on high-dose steroids, and it did resolve. Although to this day, the patient Wenke box at about 140 beats per minute, but they do not have anything beyond Wenke Bach and only at faster rates. So I think that would be the two options, would be to either take out the device. I probably would have favored taking out the device. I mean, there would be no harm in saying, well, let's do it on Wednesday if it's Monday and give steroids in the interim and see what happens. But I would certainly, at minimum, have this patient scheduled for surgery. Now, you could potentially take the device out in the cardiac cath lab, but I think that since the patient has a large ASD and you're going to have to close it anyway, I would just as soon have a surgeon take it out, which would be very easy for a surgeon to do, and then just close the defect on the way out. Also, the very large ASD devices, although they are retrievable, they're difficult to retrieve. They have to be crushed down. There are newer tools to do that. But there's actually a new tool called Oh No, which is manufactured by Matt Gillespie at Children's Hospital Philadelphia, which is designed to pull in big devices that have embolized in the heart. But the bottom line is it is retrievable, but I would be somewhat concerned even that the process of pulling on the device might actually exacerbate the degree of AV nodal dysfunction. One of the interesting questions would be if a surgeon did go in, should they put wires on the heart for a pacemaker or not? I don't know the right answer to that. I probably would favor not putting wires on the hope that it would recover, but it's hard to predict. But steroids in this particular case apparently worked and resolved the issue for the patient. Okay. All right, let's move forward. All righty. Actually, let me go to this one first. Okay, so this is an electroanatomical display of catheters. We are looking in the LAO projection, and we have catheters A and B, and then there is an ablation catheter, which is this catheter here. So I'm going to ask you to name catheters A and B. Why don't we ask Dr. Marshall what she thinks?
Okay, so catheter B looks like it's in the coronary sinus.
That is correct.
And then catheter A, I think would be a HR or a high RA catheter.
All right, that's a good guess. It could have been a high RA, but it's actually the His catheter.
Oh, okay.
Now, the reason it's the His catheter, or the way you would know that or imagine it is, so the catheter, this is the CS catheter, as you said, and this is the end of the CS catheter.
I see. Yeah.
So basically, this area here should be the mouth of the coronary sinus. And so that should help you understand electroanatomically where the atrial septum is. And so this catheter is very close to that. It's very septal, and it's also, so this is pointing posteriorly, right? Because remember that the coronary sinus surrounds the mitral annulus, which is leftward and posterior of the right atrium, so that anything pointing in the opposite direction is going to be anterior and forward pointing. And so the fact that it's pointing in this direction as opposed to this direction means it's anterior. And the fact that it is so close in line with the mouth of the coronary sinus would be very highly suggestive of it being a His catheter. Okay. Does that make sense?
Yeah.
And I suspect, I wasn't at this case, but I suspect that this white dot probably denotes where the person who was doing the map thought the mouth of the coronary sinus. Sometimes when we're trying to put the CS in, And this one looks like it was put in from above based on the shape of the catheter, the way I do normally. If we're having trouble, we'll come up with the ablation catheter and tag the mouth of the coronary sinus to make it easier in terms of aiming where to put the catheter to get into the CS. Where do you think this ablation is occurring, Molly?
It looks like within your ablation catheter, it looks like it's kind of following the direction of the coronary sinus catheter and more like you meant, like in terms of anterior posterior going posterior. But so I'd say it's a left-sided, probably more towards lateral pathway or a left kind of more posterior pathway.
Yeah, this is a left-sided pathway. And so just so that we all are on the same page, what is the normal convention of describing where you are, like when we say left posterior or left lateral? So when you're in the LAO view, you can think of we think of the mitral annulus, it's here, right? Virtually. And so we think of it as a clock face with 3 o'clock being over here, and that would typically be left lateral. This would be anterior, this would be posterior. So this would be, I guess we would say left posterior to left posterolateral. So you can understand why when we do ablations on the left side, right, we're crossing the septum here because this looks like a system that doesn't show you the back of the catheter as some of the newer Carto ones do. We can't tell exactly the direction, but what we know is this, right? The mouth of the CS is over here. So you're crossing the septum in this plane as I'm drawing here. So you could imagine it's pretty easy to ablate things that are around here because the catheter is sort of naturally, as it crosses the septum, pointing in that direction. And the catheter will fairly easily retroflex down to here or maybe even to here. But when you need to ablate things over here, what you're asking the catheter to do is essentially do almost a 270-degree turn or maybe even close to 360. So ablating things that are leftward and posterior, like over here, can be very challenging. So sometimes what will happen is that we'll go in on the right side into the coronary sinus and see a good signal, but we realize that it's still not very early. And then we have to cross the septum and then turn the catheter all the way around to come over here. So when we're doing ablations transeptally on the left side, this area here is generally the hardest. This area is very difficult to ablate or more difficult than some others. And the other one that's very difficult is over here, this area, sort of antero-lateral. And why do you think that would be harder than, say, ablating over here, Molly, to ablate a pathway over here?
I mean, it looks like just how you were mentioning, like the catheter doesn't necessarily, like you'd have to turn it to go that way versus how it kind of naturally would cross the septum.
That's right, yeah. That's one certainly true. So first of all, as you know, all of our catheters are what we call bidirectional, the ones that we use, meaning that there's a handle on it that will allow you to flex it down, as this catheter appears to be doing, or go the opposite way. And by the way, that's a relatively new invention. It's only been around for about 10 or 15 years. Previously, well, the original ablation catheters were fixed curve. So basically, it had no bend, it had no deflectability at all. So you had to be really, really good with moving sheaths around. And some of you have seen that Dr. Love likes to use the Agilis sheath, which itself has deflectable qualities to it, which is why he likes it a lot and why a lot of electrophysiologists do. But it turns out that that also is a relatively new invention for like the last 10 to 15 years. So in the past, you needed to have really outstanding cath skills in order to get the catheter to go pretty much anywhere because it really didn't have any deflectability at all. Now the catheter can be deflected upward, but the other problem or the other difficulty of ablating things that, shall we say, live over here is you notice the coronary sinus catheter stops here. So when we're mapping pathways that are over here, we are looking at the signal in each of these pairs in order to determine which is the earliest pair. Now, it might be that this pair is earlier than this pair and is later than this pair. but it doesn't, so that doesn't really tell us if all it tells us is it's somewhere from about here to here. But at least it gives us an area in which we know this is the general vicinity of the pathway because we have a coronary sinus catheter here to help guide us. There's at least one electrical stable position that allows us to know where the earliest timing is. Once you get past the tip of the distal ablation catheter, you're kind of in no man's land, and you really have no idea. In this type of case, the earliest signal will be on the distal ablation catheter. But what we don't know is if distal coronary sinus catheter. What we don't know is if the coronary sinus catheter could extend farther. If we could somehow get it to go out to CS here, would there be an electrode over here that would be markedly earlier than this one? Okay. So whenever we're doing a case, like let's say someone who has WPW, and when I see that the earliest signal is on the distal ablation, on the distal coronary sinus, I'm usually getting a little nervous because I don't know if it's like right near here, or there might be an area way over here that's actually earlier here. And the other thing is, it's just hard to stay on the annulus up here. So you don't have the guide of a coronary sinus catheter when you're all the way up here, which makes it harder to know, is the pathway here or here or here? And then the other thing that's hard is that it's actually hard to point by point move around this area. It's not impossible with deflectable sheaths and deflectable catheters. We can do this, and we do this, but it's actually much easier to deflect the catheter down in this region. It sort of naturally falls here with relatively little movement and twisting on the catheter. To go in this direction is actually very challenging. And so now the good news is most pathways are around this area, in the area where it's relatively easier. So posterior to lateral or posterolateral is where I think the majority of left-sided pathways live. But when they're over here, this is where we start having occasional failures. It's one of the more common reasons we have a failure in ablation. And this area over here can be sometimes a reason for failure because of difficulty getting the catheter to come around. And we have different kinds of sheaths. Barry will use the Agilis and just torque the sheath down this way. There's also something called an SL, or a Swartz left sheath, that actually makes a curve like this. It's literally a turning sheath, and then you push the catheter out and it comes out on this area. So there are ways to manipulate it, but as some of you may know, left-sided pathways don't have to be ablated transeptally. There are still electrophysiologists who will do it retrograde and go up the descending aorta into the ascending aorta, cross the aortic valve, and then retroflex the catheter up across the mitral annulus. Now, that might seem a bit of a lot of turns and complicated catheter manipulation, but actually amongst people who do that routinely, they'll tell you it's very easy, very straightforward, very quick. And they actually think that doing a transeptal is dangerous. And they'll tell you that, and people have done studies assessing whether transeptal or a retrograde approach to pathways, which is more effective. And it turns out that they're roughly the same. However, if you were going to say to me, is there any location where a retrograde approach might be preferable? This area here is actually easier to approach retrograde. The catheter, when you go down the aorta and come back into the LV and retroflex up, this is an area where it sort of naturally starts. And I think as you move outward, although it's absolutely possible to ablate out there retrograde, and people do it all the time, this area is an area that is, I think, in my view, is the only area that is clearly easier to achieve position in retrograde. But I'm sure you've noticed that both Dr. Love and I rarely go retrograde for left-sided pathways. And the reason is that you can reach most of them transeptally, and that's what we do more often, and so we're more comfortable with it. But it doesn't mean that it's the only way to do it, of course. I've seen both. What's in the old days when there was no such thing as an atrial fibrillation ablation, adult electrophysiologists did all their left-sided pathways retrograde. They never, ever went transeptally. And I remember when there was a rare case that they needed a transeptal, they would ask me to come and help them when I was at Columbia. And that all changed with AFib ablations because, of course, to do an AFib ablation, you have to ablate around the pulmonary veins. So you must be in the left atrium, and you have to be in the left atrium for long periods of time. And so everybody needed a transeptal, and oftentimes they need two transeptals. And so very rapidly, adult electrophysiologists became better at doing transeptal punctures to the point now where I think a very large number of them will even do left-sided pathways transeptally because they have so much more experience today in doing transeptal puncture than they did before, because of the requirement for AFib ablations. Okay, any questions about that?
No, thank you.
Well, I think with that, we're going to stop for today. Dr. Compton, congratulations. You've made it to the end of the finish line, as it were.
Thank you.
We're going to miss you in conference, that's for sure. So,
Likewise. Thank you
all
so
right.
much.
Have a
Take
great day, everybody. Be well. Bye.
Thank you.
Thanks, bye.